longevity is just, rebranded prevention, right? A lot of people care about it, but it's now increasingly happening outside of medicine because we as doctors were trained in evaluating patients who have symptoms, diagnosing the condition, managing the condition, and trying to prevent further progression or complications related to that. Now, preventing the onset of the symptoms, onset of the disease itself is not like a major focus area currently in medical schools. And, maybe you learn a little bit later on in subspecialty training. And there are a lot of challenges there. And some of it is just related to how medicine is and how it's funded today.
Dr. Pradeep Natarajan is a preventative cardiologist, physician scientist, and leader in cardiovascular genetics at Massachusetts General Hospital and Harvard Medical School. He directs preventative cardiology at Mass General and leads research leveraging genomics and large-scale data to better predict, prevent, and treat cardiovascular disease. His work sits at the forefront of precision medicine, translating genetic discoveries into tools that can be used in everyday clinical care. Pradeep, welcome to Bluestock Talk.
Thanks so much for the invitation.
Absolutely. So I confess, many of the folks that I have on this podcast, I've, not really met before, or that we don't have much of a background because I've just been seeing stuff that they do on LinkedIn. But you, sir, are one of the people that I have known the longest. I have known you longer than I haven't known you because we went to college together. So fun fact, we were both UC Berkeley undergrads, and we were both mentors in the biological sciences program, whatever. Like, we had office hours, if I remember correctly.
That's right. Yeah, go Bears. Yeah,
Go Bears.
We were part of this organization. Man, I should have looked this up. It was called MCB cDNA because we were part of the molecular cell biology major. The cDNA had some like cutesy acronym along with it, but it was like kind of the student advocacy group, and we would help people who were doing different things. I remember hearing some statistic that like 10% of Cal was MCB. It was totally crazy.
I mean, science is cool.
Major. We made it through and lived to tell the tale.
I remember feeling so proud that I had received a C- in organic chemistry because it was the hardest class. I never failed a class at Cal, but that C- was the hardest fought grade that I busted my butt to try and pass that class.
I mean, people outside don't realize just like, I mean, I don't know that I would say necessarily it was like cutthroat or anything like that. It was just like so many amazingly smart and creative people, and the class sizes were massive, and these were the grades are probably, there's some distribution, but it was, I mean, it's such a wonderful place. It was like daunting coming in. Like, I remember Chem 1A, right? Each of the class sizes were, I think, almost 1,000, and there were multiple sections of that.
Like three Chem 1As or something, like it was, and they're either each 1,000 kids.
I mean, you grew up really fast in that kind of scenario, right?
That's so true. And I felt like it was all of a sudden, like I went to a great high school, not knocking my high school, but I remember walking into Cal and being like, oh, wow, everyone's so smart here, and everyone is also like really working their tails off to try and make it to the next thing. So it was grew up fast as a scientist. So with that in mind, because I knew you back when, and I know that I never looked at my life and my trajectory and was like, I want to be a regulatory consultant, or like, I want to go work at FDA. Yeah. Like, that did not cross my mind back in the, when we went to college. We shall not say dates. I never asked you, like, or maybe I did and I don't remember, but what was your goal? Like, you've had such an amazing path, and was that like, you did everything you wanted to do, or has it kind of like changed over the years?
Look, I had a strong sense that I wanted to go to medical school. Early on, surprisingly, was interested in cardiovascular disease. And I think just because it's common enough that you hear about it, that it's something that you could get excited about. But I was interested in other things. I mean, like the only times I would go to the doctor would be sports injuries. So I was like, oh yeah, maybe orthopedics would be cool. I grew up in LA, being a doctor for the Lakers. I was like, all that stuff is, what normal, I think kids will think about. Um, but I did some research at Cal, and it was in the spectrum of cardiovascular disease. So I was like, oh, that's kind of interesting. But I didn't have like a really strong sense of even what like combining medicine and research would even look like at the time. I mean, now that's heavily what my life is right now. I was like, this is a long road. I was excited about what that endpoint would be. So I mean, I didn't take any time off to like really explore that part in depth. I would just do it longitudinally with all of my experiences, like, the research and stuff.
Yeah.
And at the time, like, the cardiologist stuff that was exciting, just like, dealing with acute issues of broken bones and stuff, was saving lives related to heart attacks. And that's the field of interventional cardiology. So like that's changed, right? I'm a non-invasive, I'm a preventive cardiologist, and I spend most of my time doing research. But I think that like kind of anchored in the cardiology interest, but didn't have like a sense of how all that would come together. And maybe because like Cal didn't have a medical school, maybe that's why we didn't get exposed to those things. It was science was one thing, maybe medicine another thing.
Yeah. That's fascinating. Yeah, because I feel like there were a lot of folks that were pre-med. Like a lot of folks knew that they wanted to be medical doctors, but you're right. Like the closest medical school was, the farm across the bay, as well as UCSF, right? Like,
yeah. UCSF a bit closer. I mean, I ended up, I was there ultimately, but it's still the two seemed different. But only like when I went to a medical school, I was like, oh, there are actually people doing both of these things. They're saving lives. They're advancing the field. The first physician scientist I worked with was an interventional cardiologist who had a lab. I was like, oh, that's like, I was doing some stuff in the lab. How is this clinical doctor actually doing both? And these things actually seem to be related. That was interesting. Actually, his name is Yerim Yegiazarians. Yerim had tried to convince me to take time off within medical school to do research. And I was like, look, I'd decided MD only programs, didn't apply for MD PhD programs. And I was just learning how long the path was going to be with residency and fellowship. And, friends of mine from college were already out there getting jobs. So, I mean, I think it's like the mental state and maturity at the time. I was like, I want to be a doctor. Why interrupt that process? Not understanding what all those possibilities would be. But that's where I first kind of got exposed to the notion that these things could come together and lead to a fulfilling career.
Absolutely. Yeah. So how did that research piece then come in? Because as you said, like it was not something that you were focusing on. What was the turning point or the inflection point for you?
Yeah, I mean, I'll say I was, research adjacent for many years, and it was always related to coronary artery disease. And by adjacent, intensive summer experiences, trying to do things longitudinally during the school year. And increasingly, it was gaining more relevance. I was learning about human biology and human disease. And then actually, after I finished all of my clinical training, that's when I had exposure to what research would look like that was kind of more directly related to patients. I mean, because what I was doing before, mainly in vitro studies and cell culture, and then trying to model these things to understand disease or make inference about disease. And then the field of human genetics and population genetics to try to infer disease biology directly from humans, and that all the technical aspects related to that was flourishing. That was flourishing in Boston. It was also flourishing also in the Bay Area, but it was in maturity kind of at the time that I was finishing up my clinical rotation. And so I just happened to be at a place where all of this stuff was coming together. And then I said, okay, now might be the time actually to take some time and really learn this, because this stuff is really exciting, is more directly connected to what I want to do with my life. And now let's take the risk. Let's take some time. And, after doing a bunch of clinical training, then you have a little bit more maturity on what are the questions that are interesting to you. And then you can, spend the time and try to tackle it. And then you also have, if that doesn't end up being interesting or if it doesn't really work out, you can just kind of continue the path and, be a clinical doctor and do other things as well. So a lot of it was time and place was happening in the field. And then the last part was like getting hooked up with like really good people. I say people first. I mean, they're obviously mentors, but like really good people who saw that, somebody who hadn't necessarily done research in this vein yet was curious, asking interesting questions, willing to dedicate and put in the time, then they would put in their time and resources. And that's obviously critical. And then, the institution has to recognize that and all that as well. But a lot of it, right time, right place, and being open. But I think, kind of peppering and with these things throughout the time just kind of kept my mind open to that possibility.
Yeah, I love that. I feel like that you have to keep that open mind into seeing is this a time to pivot, or is it, not even pivot completely, but is it time to reassess and figure out if this is something that I want to pursue now? So that's awesome.
Yeah. I mean, because it's not something you take lightly, and it almost feels a little bit weird, right? Because you spend all of this time being a clinical doctor, and now the prospect is actually spending less of your time as a clinical doctor. How does it come together so it doesn't feel like a career change? Like I always tell folks, at least for the non-clinical things that you do, you don't want them to be just like separate and, kind of figure out how they're additive, but they've got to really work together. It's really got to be synergistic. And then it feels like it makes sense. And I think that's the cool thing in medicine. There's the opportunity to, directly make an impact with the, routine encounters. I'll be going to clinic right after this. And then, the questions that come up that patients come up with, or when I'm talking to other physicians locally and broadly, like to now have the skill set to say, okay, I mean, there's lots of equipoise, lots of outstanding questions in medicine. We can't address every single one, but there are a lot of things that we can kind of take back to the lab and start to understand. And that's really cool.
And I think there's also value, and I saw this with, or I see this oftentimes with founders and folks who are, entrepreneurs, but they're medical doctors first. And so they've essentially taken an idea and they're still in practice, or maybe they're seeing patients, half the time. And then the other half, they're trying to build something or trying to help the patient population that they see struggling day to day.
Yeah.
So it's, and having that ability and sort of that flexibility and also that mindset to say like, okay, this is something I could do and take the time. Very cool.
I mean, I think this is basically like similar balance, right?
Yeah.
Where I spend most of my time investigating and thinking about the field and trying to, address specific problems. And that can be done entrepreneurially and other ways as well.
Yeah. So I want to go back to preventative care, because I think that there's a lot of conversations right now in the world happening about, are we too reactionary, right? We wait until somebody's really sick and then we're like, oh, now we should fix you. And I'm sure there's a lot of folks that just want to be, the ER doctor, or the ones that are in the trenches kind of doing the not preventative. What is it not preventative? It's when you are...
That's just regular medicine, right? That's what we...
I feel like, is there a word for it? It's
prevention is actually not common in medicine.
It's so true. It's just medicine. And then there's... I feel like it makes so much sense that if that you're going to, your car is going to run into something, maybe turn the wheel now before you run into the boulder that's ahead of you. This seems like a dumb question, but I don't think it is. Like, what are some of the benefits of preventative care, and why should people care more about it and put more attention towards what you're doing?
I mean, look, the thing is, everybody cares about it, but there's just so many reasons why it has not advanced. I mean, we talk about longevity now. Longevity is just, rebranded prevention, right? A lot of people care about it, but it's now increasingly happening outside of medicine because we as doctors were trained in evaluating patients who have symptoms, diagnosing the condition, managing the condition, and trying to prevent further progression or complications related to that. Now, preventing the onset of the symptoms, onset of the disease itself, is not like a major focus area currently in medical schools. And, maybe you learn a little bit later on in subspecialty training. And there are a lot of challenges there. And some of it is just related to how medicine is and how it's funded today, right? Because the only stakeholder, at least in the US, that is responsible for your healthcare from birth until death is basically you, right? Without a single payer healthcare system, we're all going on different health insurances every 5-10 years. The average is actually much less than that in the US. And so for somebody, like when you think about quote unquote value-based care, the value is largely related to who is paying for your insurance. The value for lifetime prevention or even intermediate term prevention does not sit with the insurer who is currently insuring your healthcare, because they know that you're going to roll off at some point, and then at some point it'll be Medicare. I mean, Medicare will deal with the brunt of it, but because they're not engaged for the majority of Americans who are, basically non-Medicaid, they don't have an ability to address the needs of Medicare like earlier on. So a lot of it is systemic. That's one part of it. Generating the evidence requires something that is a longer horizon, really, to show long-term benefits, really for, randomized controlled trials that really drive practice. Because it's like to do these things efficiently, you want a high-risk population who is more likely to have the events that you're interested in over a shorter period of time. It makes much more sense for the cycles of the investment, the 5-year RO1 or, most of these for clinical trials. Designing that in primary prevention, the absence of disease and then the onset of disease, that's really hard to do. We don't have great tools in identifying the highest risk patients who don't already have disease. And if we did, because they're inherently lower risk than diseased populations, it will take longer and cost more. And again, that kind of relates to, without there being a single body who is interested in this beyond single individuals, it is hard to meaningfully achieve. But, other places like the UK, which has, single payer healthcare, they're doing a lot more things transformatively and thinking about long-term health. I mean, there are other downsides and challenges in healthcare access with single payer. So I'm not saying that's the panacea for everything. But I think the important thing to recognize is there are many reasons why we all care about it, but we're actually not achieving it currently. And people are kind of going outside of the healthcare system. And I'm glad that that's a marker of interest, but that causes a lot of disparities because only the people who are reasonably well resourced are going to be able to spend enough to, take the time off that they need and, have access to the right foods. And then I'll say separately, there's a ton of stuff that is non-evidence-based that are making numerous claims that kind of go in and out. And so it makes it really hard to do this meaningfully well. I could talk about this for a long time because I think it is really important. There are many things that are being conflated now that have, low quality evidence. There are things with good evidence. And we really need to think about how are we actually going to make this sustainable and high quality.
Right. It's like the folks that are saying, your doctor doesn't want you to know this. I'm like, yeah, they do. Yeah. Or there's research that's like, no, the scientists do want you to know that this is something that can help you. So to your research, like this is a nice dovetail, and you just, I think I can announce it now, but you were just promoted, and this is a very exciting time for you. So congratulations on that.
Thanks.
And it has a lot to do with the research that you've been doing. So can you tell us a little bit about that side of your role at the university?
Yeah. I mean, for heart disease, since, the mid 20th century, there's recognition of things like cholesterol, blood pressure, glucose, smoking that influence heart disease. Those are foundational insights that have not changed. Actually, that was based on a transformative investment by the federal government in the 1948 Heart Act. There was actually key anecdotes at that time, including FDR succumbing to a fatal stroke in office, where cardiovascular disease was becoming increasingly common. And the federal government said, we actually don't know much about the disease, and we have to invest a lot to really understand. And you can see that significant investment at that time, that has had durable benefit. Now, fast forward to 2026, heart disease is still the number one killer. Cancer is a close second. It's a dubious distinction, but we've been focusing exactly on the same modifiable risk factors. Turns out just how old you are is the strongest predictor of disease, but disentangling what the causal factors are really hard. Okay, so we need to figure out a framework to discover new things and enter in human genetics. So, the typical approach for identifying a risk factor could be, correlating what that biomarker exposure is with the outcome. So cholesterol, cardiovascular disease. That has panned out to be a causal relationship, and the way that you verify is through randomized controlled trials. Those are quite expensive to do. So obviously you need to, form a good basis beforehand. Now but as I said, age, gray hair also correlates with cardiovascular disease. Dyeing your hair, probably is not going to influence your heart disease, but it may make you feel youthful. It may make you do other things. Sure. So that's the challenge, right? Correlation doesn't necessarily imply causation. So human genetics, these are risk factors or potential risk factors exposures that are established at conception, and the germline genome is static until death, right? So whether you get disease or not, the various different factors are not going to influence the allocation of the alleles. They're all totally set. It turns out then that makes it actually a pretty good basis for causal inference when you establish an association. Now, there's separate challenges in then saying, okay, after you've made discoveries of genotype, phenotype correlations, to then unpack the mechanisms, because the best powered associations are genetic variants that are common, because, the 20,000 genes that we have some importance. They're generally not variants that break genes for the initial signals. They're often in between genes and have some regulatory aspect, going back and figuring out, what are the causal gene or genes or causal tissues and cell types. That requires a lot of work. But when you start with that signal, you're like, okay, there is something meaningful there. For example, we know statins reduce risk for cardiovascular disease, and the signal for the gene HMG-CoA reductase comes up as well too, now kind of in retrospect. And in general, pathways or genes or targets that are validated through human genetics are more likely to be successful as medicines. It's roughly about 2.4-fold is the rough estimate for if you have human genetic evidence from pre-IND to ultimate success, or at least FDA approval is about twofold enrichment.
Yeah.
So and that's helpful because that's in the target organism itself. So from that, we've nominated, new risk factors, new pathways. There are medicines now that have been approved, some of them in flavor of breaking genes, like PCSK9 is a new cholesterol lowering medicine, news in about 10 years ago. Work done by others shown that when you have genetic variants that break the gene, they have lower cholesterol, lower risk for heart disease. That was recapitulated in broad populations because that's just a foundational insight made in a subset of individuals. And now they're highly successful medicines at lower risk for heart attack. Made similar observations now in other genes called ApoC3, ANGPTL3. These are approved medicines to improve lipids, and we'll see if they influence risk for heart disease. Lipoprotein little a is another risk factor that people are excited about, and the genetics also point to it being potentially causal, and soon we'll know if that's the case because the randomized controlled trials are now wrapping up. So a lot has been done in this space. And then kind of even taking it one step further, we can actually take all of these genetic signals, kind of regardless of the mechanisms, and actually have that together as a genetic risk factor. And now quantify that for an individual and then understand their risk now much earlier in life. And that's also work that we're doing as well that can really help us identify the highest risk individuals, so that who are the ones that you need to invest resources in and might be compelling for earlier risk interruptions through diet, lifestyle, or potentially medicines in a subset.
You're totally right that this is rebranded, or longevity is rebranded preventive care. Because it's you can personalize this so everybody is so different, right? Like I am unique from anyone else in the world, and my genetics have never been seen before exactly. And so how Like, what are the things that I should be focusing on, or what are the things that my DNA is essentially, and my risk factors and the various lifestyle choices I've made to, what are those things that are actually going to feed back into things that I need to focus on to live a longer and hopefully healthier life. So that's so
But
cool.
this is the challenge with prevention and where precision is necessary, because,
Yeah.
you know, when I'm talking to a patient about potentially taking a medicine to reduce the risk for heart attack, you know, and a lot of the people I'm seeing, you know, have not had disease. So they're feeling well. And the prospect is taking now a pill every day, and that, you know, maybe changes the framework in their mind of where they are with their health, right? So that's one. Cost is generally negligible for most of these things. But let's say they'd never get a heart attack. Either the pill worked or it didn't work, and you'd never
You
know.
never know.
So
Yeah.
you have to have tools that give you and the conviction that the patient's going to benefit, and the ability to communicate that back to patients. And it's not easy. It's challenging. We talked about like all the various different reasons why prevention is, that maybe hasn't been as well funded, or at least, valued appropriately. But even just that encounter of saying, okay, these are the things that you need to do when you're feeling well, that's really hard to do. And, people, I think, appropriately push back, and it's often challenging to communicate these things because there is also a lot of uncertainty, and the prospects are different, when you don't have disease. There are other tools like, at least in the cardiovascular space, where imaging has been really helpful to really identify disease processes early that are more tangible, like the buildup of plaque. Then that increases the appetite of, prevention avenues. So.
Yeah, but you're right. So many people wait until they have their first heart attack to realize, like, oh wow, there's something I should take care of here. And
Yeah.
I mean, that's a cardiovascular rehabilitation, like all these things, they're very valuable. It's so important. But it's like, wow, I would have much preferred to maybe have taken that pill every day. I think it always comes down to like, what's the risk benefit for each patient. But it is very hard to convince people, if you take this pill or if you take this shot, you're less likely to have a disease down the line. What are some ways that you're able to talk to patients and make that something that they can understand?
Well, I mean, look, so much of these conversations are actually about non-pharmacologic things, about exercise and diet, because that makes a huge difference. And doing these things earlier in life is more likely to benefit them compared to later in life. And earlier in life, a lot of people are not thinking about their health. I'm obviously not saying every person. I'm saying those who have something that indicates risk. It's often in the family. So they have some activation. But, in population-based analyses, those who are optimal on diet, physical activity, sleep, stress, things like this that are, easy to talk about but hard to actually achieve, have significantly lower rates for cardiovascular disease. Sometimes there are also markers for different things about the jobs and the resources and the income that they have so that they can actually make the time. And so we have to be mindful of those things. But a lot of it is how to achieve as many of those aspects as optimally as possible within the context of each person's daily life. And that's like the sweet spot and the nuance here. This is, really hard to achieve just kind of with generically kind of Googling things. The problem is because there's so much low quality science. There's a lot, research has different qualities as far as, going from just like, N of one anecdote to a randomized controlled trial. But often when folks are reading about this, it's kind of all lumped in together. And so going through what is known, what is high quality evidence, what are things that, could be plausible, but the evidence quality isn't that great. How does that apply to a specific individual? That's the key. That's the challenge. This is why I don't think yet AI will replace us, but who knows? I think those conversations happen variably so in the doctor's office. I have the luxury of being a preventive cardiologist where I can focus this, but most of these conversations are kind of trying to fit into routine primary care visits where
Right.
it's hard to spend as much time on that kind of nuance.
Yeah. And I'm hopeful that AI, there's so much conversation about it. And you said it first, so I'll continue the conversation. But it's, and I just had hung out with my friend who's become a nurse recently. And she said the thing that blows her mind is the amount of charting and the amount of writing that she has to do in healthcare. And I think a lot of my friends who are medical
Yeah.
doctors as well, it's like, oh my gosh, the amount of work. And I have seen some of the, what are they, like the note takers and the smart charting
Yeah.
tools really bring doctors back to the patient so that they can actually spend more of that time talking to them and answering
Yeah.
questions. Because I think people are asking more questions, rightfully so. And you
Yeah.
want that time and that trust. That I don't think AI is ever going to take away that face-to-face time with the
Right,
physician.
right. Yeah, I mean, I totally agree. I'm really excited about AI tools and LLM tools to improve the clinician workflow, and I think there are early insights that suggest that they could be helpful through that vein. I think the challenge is if the thought process is increasingly outsourced and there's limited opportunity to like really be able to communicate and personalize and develop that therapeutic alliance with patients, then that could be a downside. However, though, if the workflow is being optimized such that one has the time to impart that nuance, and then it could be really helpful. But some of these things are also at the whim of the healthcare economics, right? Like if the healthcare providers, if the physicians and the nurses have more time, are they going to be asked to see now even more patients? And then
Right.
it's just like, it's re-narrowed again. So cautiously
Yeah.
optimistic, but we have to
Same.
think about the other external pressures as well too.
Absolutely. So we've talked a little bit about sequencing and finding biomarkers, and those are all, this is of course an amplification of MedTech podcast. So I always love talking about how those are being used in vitro diagnostic tools as well as med devices. But I want to, this is a question I ask of all my guests on, what is a MedTech or medical device that has personally benefited you or the life of a loved one?
Great. Yeah. I'll two separate issues. So at least the assay part for genetics, the cost of sequencing a human genome is plummeting. It's less than
Yeah.
$100 to and this was not really even well conceived that this could happen 5 years ago,
Right.
10 years ago. That makes the ability to do things like genetic risk scoring, or now called polygenic risk scoring, and broad scale genetic diagnosis at the population level, let alone just to individuals who have suspicion for heritable disease. And so that can now move into the realm of earlier risk prediction at reasonable cost. And the value also improves because, within the single genome, you can calculate risk or estimate risk for any number of diseases. But this also has really interesting, regulatory implications and standardizations, because the algorithms are continually evolving, and they're evolving because the methods evolve, how we interpret the genome evolves. So the genetics, the assay part, like sure, that'll keep getting cheaper, but those base pairs for you and me are the same.
Yeah.
They're unchanged, at least for us.
Yeah.
Right. So, but our interpretation and reinterpretation is evolving, and this is like, it's a little bit of a wild west right now in genomic interpretation. There are many different companies out there. There are academic institutions, all well-meaning, but the lack of standardization sometimes means that if a patient goes from one place to another place, they will get different results. So that trust also, that leads to problems with clinicians, to be honest, because what you and I learned at Cal in genetics was obviously at the forefront at that time, but so much has changed, so much has evolved. And so the clinicians and the patients, they're not spending their time thinking about those nuances. And right now, if I go get lipids checked at, one place versus another, they're all basically going to be about the same. But this complexity does pose important challenges. And that's something that now I think more deeply, because that I think is one of the most important barriers to having this realize its, broader adoption. Okay. And then so for medtech, that has helped me, there's not anything in genetics because this is all new. Maybe in genetics because for my career. Is more related to fitness and lifestyle and wearables. I mean, I wear an Apple Watch. I'm not getting paid by Apple right now, so it's
I
not a
am.
specific
No, I'm just
endorsement.
kidding. I'm not. I wish.
It's not a specific endorsement for Apple. But actually, one of the first grants that I got when I was starting my lab was actually from Apple to help them with their, at that time, very new VO2 max estimation.
No way. That's so cool.
And because, I oversee preventive cardiology, which includes cardiac rehabilitation, and these are patients with symptomatic cardiovascular disease on vasoactive medicines and heart rate modifying medicines who are on treadmills, who are being monitored, and they're getting these estimations. And so since that time, for many years, almost about it, probably since the first Apple Watch, I've been wearing an Apple Watch, and I've been really impressed with how things have improved and just the new insights, because I also used, Fitbits earlier than that and focused on the steps. And so I've been excited, now really thinking much more about using these tools for fitness beyond just general activity. And that's helped. It's helped me. It's helped others. My parents wear Apple Watches and they really think about their activities, looking at the heart rate trends, resting heart rate, what the heart rate goes up with physical activity, including walking and running, and the estimates of VO2 max, which I take some pride in. I mean, in its use as well. So, and I've tried other algorithms, and this is the challenge, right? Because some will give you a lot of information and they make a lot of claims, but most of these are relatively proprietary. So you don't really know about the validity of the claims. I come at everything with some mild degree of skepticism, but also some optimism. But if there are just so many things out there and they're generally telling you how poor you are doing, when for somebody like me who's reasonably active, I go to the gym every day, I'm like, that I don't really understand what we're doing here, or maybe I'm not necessarily the right demographic. But these things are getting more and more sophisticated, and I think they have the prospect of having substantial public health good. Hard to study, but certainly, monitoring for me has been helpful, and I tell patients to monitor as well too. At minimum, monitor their steps and their heart rates during physical activity.
Yeah.
So
that's so cool.
Yeah.
I feel like the wearables, especially FDA's big push recently for home as a healthcare hub, and the ability to move a lot of the technologies into the home, right? So for cardiac rehabilitation, how do we get them, especially folks who are hours away from any sort of facility, to get support? Are there ways that we can send devices to the patients? Are there ways that they can have a wearable that's monitoring them that then alerts the physician or tells somebody, hey, you might want to call this person or have them come in? I really am excited about that as well. I feel like that's I don't have one. I full confession, mostly because I feel like I would look at it all the time. I think everyone's so different in their, of course I have it on my phone, right? It counts my steps and I look at the health app. But I'm so concerned that I would just be totally hooked to it. I would be.
That's the thing. You have to. It's all very personal. Some people really want all of those things, and I like having more data compared to less. The problem is when it's unvalidated and it's a lot of made up words for kind of pulling all these things together without actually seeing what it's connected to, what it actually means. Then I'm like, okay, there's just too much mental bandwidth for nothing. So when patients come to me, whether they just have just a smartphone or even a wrist-worn wearable, I always ask them, how many steps do you normally take? That gives me a great proxy for just generally how active. That can be the basis for many of the conversations related to exercise.
Yeah. Yeah, I a lot of my rowing buddies, because if you remember, I rowed at UC Berkeley, and then I still row. And so many of my friends have their wearables, and it's amazing because it tracks where you went and what was your heart rate at certain parts of the pieces. And I'm like, oh, this is so cool. we're living in the
Yeah.
future.
But yeah, actually for outdoor activities, I mean, I generally am like very focused in the gym, but you know, when the weather is nice, go out for runs. I like to see but like I can see what my pace has been and then understand, you know, what my heart rate was in response to that and how can I improve. And these are things that like, you know, I think once you start to get some of these things that are put in the device and you can start to play around and they're like, you know, not crazy metrics, then I think there's an opportunity to continually improve and work on your fitness. And, you know, you wouldn't have that otherwise. So,
Absolutely.
but yeah, I'm excited about this in general. Not that like the Apple Watch is the only thing, but there are other devices that have this as well too. So I'm a big fan.
I want a hot take from you then, since we have to wrap up, but there's been so much discussion in the news around blood pressure. And there have been some companies that got some warning letters, and then FDA came back and said, actually, if you're not making medical claims, it can be a general wellness product. What's your take on blood pressure? Like, how helpful is it? And should people have access to their blood pressure insights if it's, as you said, like, we don't know how accurate it is?
Yeah, you know, hypertension is the most common risk factor. It's responsible probably for the most cardiovascular disease because it's actually poorly recognized and it's hard to manage because the current approach to measure with the blood pressure cuff is variable. You know, it's variable in different contexts. It's variable if it's taken at home versus in the doctor's office. So that leads to actually just a lot of undertreatment also of hypertension as well. But like how to optimally do it is really hard to do. And most people are not necessarily like regularly checking their blood pressure as well. And when they do, when they're going into the doctor's office, sometimes it's like, oh, you know, maybe white coat hypertension, but then, you know, nobody really checks it until, you know, maybe later in middle age. So the field, you know, the folks who are making commercial wrist-worn wearables for a long time have been trying to work on this problem of non-invasively measuring blood pressure. And it's really hard to do. And I think the approach that many of them are taking now is flagging the possibility of hypertension without necessarily giving an actual number. Some do give numbers. The main challenge is calibration to be able to do it well because there may be systematic biases for a given individual. But flagging can be really helpful because it can say, okay, you're not in the doctor's office, you're out in the community, and the devices were currently detecting what it thinks might be high blood pressure. And most of them are working on specificity, trying not to give just too many hypertension indications, meaning that they might miss some, but you know would have some reasonable confidence where there is hypertension. And then that would prompt a blood pressure assessment. And that's a pretty low risk intervention because based on that flag alone, no patient, no clinician is going to recommend an antihypertensive or doing anything crazy. So I think just because the awareness is really low, I'm really excited that the field has moved to a point where it can, you know, with some reasonable positive predictive value, have this flag. So it's great. I don't know about like the very specific blood pressure values themselves, but at least the flag is really exciting. I mean, if you just go and look at the other one that was flagged earlier, this is, you know, atrial fibrillation.
Yeah.
Atrial fibrillation is a risk factor for stroke. So the consequences are pretty devastating. And there was a lot of concern that if it would get flagged, that maybe some people would start blood thinners. Positive predictive value is not that great because the overall prevalence of atrial fibrillation is really low. It's different than hypertension. So there are a number of people who would have false positives. We do have good tests where people can wear patch monitors to see if they have atrial fibrillation, but it, you know, for many of these scenarios, it's happening just as a one-off. So it may or may not be picked up by a patch monitor. And so you may still be in this conundrum, but some slight inherent risk on what the intervention could be. This is better testing characteristics, much lower risk. So I'm very excited
Net
about
positive. All right. Thank you for sharing that. That's I'm with you. I feel like there's some really exciting stuff that could come from this. And I think FDA and even just users, right, that are like people using these technologies, as we learn more, things get a little clearer for everyone. So
Yeah. And I hope these things are studied in a,
Yes.
in a rigorous manner, because, to sell the devices, these companies really don't need to do the studies. I would say, if the Apple competitors who don't have the market share, maybe they might be motivated to do the studies, because if it does show improvement in surrogates of risk, causal surrogates of risk like hypertension, then we should think about as a society or insurers or whoever is going to be paying for care that these are things that we should invest in, because we can identify these modifiable risk factors much earlier on. That's only going to happen with these kinds of with research studies.
Absolutely. Research is so important. We learned it at Cal, and we many decades later, here we are, still
unchanged.
Our opinion stays the same. Pradeep, thank you so much. Thanks so much for joining me, and congrats again on your promotion, and just keep doing all the amazing stuff that you're doing, because it is making a huge impact. So thank you.
Thanks. I appreciate it. That was great to chat. Thanks, Allison.
Right.